right, so our group talked about a couple things. We talked about how there is a huge influx of new people who work in the department, new physicians, new nurses, travelers, all those kinds of things. We also talked about how there's a greater separation of life and work with the pandemic, that it's hard to get to know your colleagues outside of work when less things are happening outside of work because of health concerns. And then we also just talked about how stress and egos while you're at work can get in the way of, difficult resuscitations, and when people get very stressed out and have different opinions on how things should go.
Awesome. Thank you so much. So getting to know people that you work with, and there's lots of turnover, lots of new faces, and also managing stress and no opportunity outside. One more group interested in sharing?
So our group spoke a little bit about the time constraint to debrief and to go over problems with people, that sometimes you know that there's a problem, but you may not have a time to go over it with everyone. We also talked about just a little bit about the culture. Sometimes that things are ingrained, that we do it this way, we're not going to change it, that's how it's done. And then also that, it's not a one-shoe-fits-all everybody solution for some problem solving.
That's so great, because in those two groups, we got, I think, some of the problems that I'm experiencing myself, and then some of the potential solution. And I just heard on the radio earlier this week, they were talking about the State House and the budget they were passing, and they said, a budget reflects values. And I love that simple statement, and to me, time is our most valuable resource, and so our values are there in the culture, and we're not spending time to solve the problems that we're seeing. So I see these conversations as rituals, as ways of structuring our day, and an opportunity here. So there's something we're doing wrong, you're calling it out. It's that we're saying hello, goodbye, and we're not really attending to it in between. And so I'll spend a few minutes here sharing some basic ideas about Circle Up and the model, and also, like Dr. Heron did in her talk, bring you a few of the users of Circle Up, their reflection on video, so you can, and hopefully that'll work, so that you can see the impact. And I think one thing to keep in mind is that you could look at this as a system of speaking and listening, which is a very task-oriented, but I want you to also look at it as a system of connecting, creating interpersonal space for emotion. And if you can hear that both of those things are going on in our colleagues' reflections, and that you can try to infuse that into the conversations, I think you'll be successful. So our goal with Circle Up is really to support people, helping put people at the center, and that's the patients and the clinicians, and both are there. And we structure that, and it's not rocket science. There's a beginning, a middle, and an end. The beginning is a briefing or a huddle. A Circle Up huddle does attend to process and protocol, and that was our experience. There were lots of changes. There was emerging data, emerging practices, and emerging problems, and so we had to be able to respond to those. We had to deal with people and teams and new faces, and that's important. So introductions are a really important part of a Circle Up briefing. And then a mental rehearsal. So we couldn't go to the sim lab, but we had to do new things, and just knowing about a protocol isn't enough to get it implemented. So doing the mental rehearsal, activating those mirror neurons, and going through the speaking exercise. So, well, how are we going to actually get this done? There's a good idea that we should move patients from here to there, but how do we actually do that? And letting people on the team talk through those logistics, and not just transmitting the command, but really letting people rehearse that in their mind. So we're investing at the beginning of a shift in connecting, in orienting, and in having a shared plan. As we go along, we have set forth this idea that we're connecting with each other, and we wanted to really raise the attention that checking in with each other, how are you doing, how can I support you, and looking out for each other in more formal ways. And so we added the peer check-ins, and we collaborated with a group called the Debriefing Academy on some guidance, really distilling what could be some productive ways to formalize. my take on debriefing in the clinical environment and even peer check-ins is that it's happening all the time, but you may not recognize it as such or formalize it that. By giving it name and structure, we can have it expand. And then finally, the debriefing or the huddle, typically towards the end of a shift. I think emergency medicine, we're lucky we have structured changeover. In other fields, they have longer days or weeks of service, and so it's really about no one size fits all. So figuring out what works for your system, and towards the end of the day, making sure that we're sharing successes, exploring challenges, and transmitting that to the administrative group, and then delivering that to the next group so that the new knowledge doesn't get lost. So let me share with you a couple of reflections from people who implemented Circle Up around the pandemic. And I'll start with a group of CRNAs at MGH, Derek's hospital, who stood up at ICU when we had to expand capacity and use their ventilators to have patients really until more space was available. And you'll hear her talk about working as a team.
Everything that respiratory therapy has done with their machines for years, we've now had to transition that into our anesthesia gas machines and the ventilator that we use through there to be able to do the same thing for our patients in the ICU world. We gave patient handoff, and then we went right into Circle Up. So it was protocols, policies, what it's looking like, the workflow. They started creating a white 3 ICU Pearl sheet and what our responsibility would be. For the first time, we're actually working with each other versus when you're in the OR as a CRNA, it's usually you and an attending. A CRNA may come and give you breaks, but now we're teams of CRNAs, approximately 4 of us on day shift, 4 of us on night shift. We're training each other and we're helping each other. So that's a whole other element that we haven't experienced before, is working together as a team. Super awesome because things are getting changed very quickly. I think if we didn't have that, it would be much more scattered.
I've been working in the OR, in offsite, in interventional radiology, and in the regular ORs. I really want people to speak up if they see an issue. I think that saying that really upfront about what I'm focusing on and hearing what other people want to focus on makes it easier for people then to speak up if they see something that would have an impact on those areas of focus. People speak up about, notice that other people didn't have adequate PPE. Like some people, twice now I've had people present at induction forgetting their face shields. And they spoke up about that, which I don't think normally people would say, like, hey, do you want to wear goggles? But I think in these times, if we encourage it, people are grateful for that. And a couple other things, like I've asked people specifically to speak up if they notice that one of us touches the oral or nasopharynx, and then we touch something else without removing our gloves. And I asked the circulating nurse who's present throughout the induction to specifically watch for that. And almost every single time they've had something to give in that area.
So when I'm hearing my colleagues talk here, what I'm hearing is they had to work in new ways, and they used the structure of the briefing to accomplish what they wanted to do. And so there's that intentionality and that setting the pace for the day. I came back to this slide so you could, I'm sorry I don't have a good QR code. Take a look at this website if you don't mind. I promise it won't steal your data. If you go to tinyurl.com/circleup SAEM 22, I have the scripts there, the structures for the briefing, the debriefing, and the peer check-ins. I'd like for everybody to pull that up. So take a minute here to pull that up so you can look at it as we go through the different conversations. If you're successful, give me a little like, I got it. 1, 2, 3, 4. I see a 5, 6, 7, 8. Okay, I think there's enough that you can help your friend if they're stuck, so I'll keep on going. I'll introduce you to Lon Sednick. He's an emergency physician in Concord Hospital. This is actually a community hospital in New Hampshire, and he'll talk about the impact of debriefing on his group. Or not.
It was clear in our organization, based on previous staff surveys, that people had a real hard time leaving work behind. And because we're an emergency department, the work never ends. We put a lot of energy into trying to make sure that the system allowed them to sign out their care before the last 10 minutes of their shift, and then everybody could meet the last 10 minutes of their shift for the debrief. Some of the nurses talked about hard things that they'd been through. One of them felt that they'd made a mistake and had to self-report a mistake that had happened. And one of the other nurses, one of their colleagues, spoke up, and he said something that just blew me away, which was, remember that all of our mistakes came from trying to care for a patient. And we didn't get the outcome that we wanted, but that wasn't our plan when we made that decision. And so he asked the question, so can we learn from it and still remember that happened because we were caring in another way for another patient most of the time, which is what had happened in this instance. The nurse's attention had been pulled in another direction, and something happened with the patient, and so they felt that they had made a mistake. But the other nurse was able to reframe it for them, was that wasn't your plan, that you were actually providing care for another patient during that time. And I think that was a really great moment where people could change how they thought about having something negative having happened in their department. People are leaving feeling like they know what it is that they do that makes their job successful, and they can teach each other, and they can feel good about their work when they leave, and they can also leave it behind.
So my experience in debriefing and trying to find the time is that I have to try and fail several times until I get it. And so it's like you're throwing the spaghetti to the wall until it sticks. So I start my shift, I'm trying to do the briefing. When am I gonna do it? Is it gonna work out? Is it dumpster fire? What's going on? Eventually, I can fit something in. Same with peer check-in. It's not like I'm obsessively running around people trying to find them, like, how are you? How are you? Can I check, how can I support you? That looked really tough. But I think if I start my own, if I start the day with the intentionality of connecting, being present, attending to the team and supporting them, then it's going to happen. And there's a ton of priorities there, but I truly believe in the payoff. How, when to connect. This is work that I mentioned, a group from both CMS and the Debriefing Academy put all their amazing brains together, and I'm just a benefactor. And I just really liked how they summarized with the infographic to say, be present, be kind, listen. In a way, it's a really powerful agenda. For me, super type A, I need that, like, okay, relax, Demian. All you need to be is there, connect. I know that's pretty simple, but then I also need some guidance, and so I'm going to, what am I aiming for? Validate, normalize, empathize. I'm not trying to correct, fix the problem. Sometimes you want to, you really do want to get into an in-depth discussion, but really you're just there, take a few minutes, a few seconds even. It's a new way of communicating and connecting in the course of a shift for me. It's not my go-to mode when I'm either working independently or working with PAs or residents. I think I also really like this guidance because after opening, there's some sharing of challenges. It's likely, it helped me do that. People talk about vulnerability. My colleague Carrie McCabe was here. She's a big proponent of that. But how do you actually enact it? And for me, sharing challenges, like I'm there too. This is hard also. I think that was really important, and is now part of my repertoire. That lovely question, how can I support you? So it's, for me, part of shifting debriefing into the clinical environment had to do with lessening this kind of idealized version of the conversation around a table, very orderly. These are images of circle up huddles and debriefings going on at different institutions, and you see people are finding space where they can. They're just gathering, just people gathering to get together. It doesn't have to be very formalized. It could be very optional, but we're starting to build a culture of connecting and talking with each other. So I'd like to now shift towards practicing and trying this out, because there's nothing like learning from experience, and having hopefully given you an idea of why this might be valuable and distributed the resources which you can now use. We'll go ahead and play a little bit. Sounds good? Okay. So just imagine you're walking into the beginning of a work day. Work with your groups to try out, to plan in your mind, and then try out a little briefing moment. And you're going to be walking into your clinical area where several medication errors and near misses have recently occurred and been identified in the resus area. And so you really want to set the tone with your team towards closing the loop and whatever else might be your agenda. Hopefully you're getting a tool here that allows you to achieve your goals as a leader. And in terms of people and teams, you've got lots of new faces, and there's a new chief of trauma and new trauma surgeons. That's some of the context in your hospital. Sounds good? Take about 6 minutes or so to work within your group to try out a circle up briefing.